Good, good afternoon, everyone. I am Dr. Ishima, and it is my privilege to welcome you all to today's session of E-Gurukul Episode 7, Series 2, titled Stillbirth Solving Clinical Dilemmas. We are once again fortunate to have with us Dr. P C Mahapatra, a teacher par excellence in Obstetrics and Gynaecology. Dr. Mahapatra has been conducting these insightful e-Gurukul sessions, offering his vast expertise and guidance and complex clinical topics. With years of experience, Dr. Mahapatra has not only been a mentor to countless students but has also been instrumental in helping clinicians navigate some of the most challenging dilemmas in the field of obstetrics and gynecology. His ability to simplify complex issues and provide practical solutions is what makes his session invaluable. Today, as we focus on the sensitive issue of stillbirth, Dr. Mahapatra's insights will help us understand better practices, preventive strategies, and how to manage these delicate clinical situations effectively. We are grateful to have him in today's session, and we look forward to gaining knowledge that will enhance our clinical skill and approach in tackling these critical issues. Without further delay, I would now invite Dr. P C Mahapatra to continue with the session and share his invaluable insights with us. Over to you, Doctor.
Thank you, Dr. Isima, for your brilliant introduction and overestimating me. And welcome, Team Juventus. And welcome all my favorite Foxians and viewers in this particular episode for that. And before going to the subject, I think happy Holi to everybody. And this Holi has become really a unique 2 days event celebrated in Puri by Lord Jagannath. And therefore, I need blessings from this Lord for every episodes for that. Now this, after finishing the surgical sessions in the series 1, we have almost completed 6 episodes and today is the 7th episode in the series 2. And thanks Team Juventus for again continuing this particular program, year-long program for that, for the benefit of the gynecologists, the clinicians, the students, and everybody in the field of gynecology who loves that. And today my topic, stillbirth, a clinician's dilemma. I've chosen for that, which is very, very important and a very common topic. And therefore, I thought I will elaborate little with the addition of my few own experiences and case scenarios at the end of this particular session for that. Now, is it visible video? Rishma?
Yes, sir. Yes, sir. Visible.
Don't think that I'm terrorizing you. This is a picture, a saddest event for a reward for 24/7 obstetric practice by obstetricians for that. And this is not very uncommon for that. And if you find a problem like this stillbirth, this is the usual event and a mob violence. And therefore, I must say the aftermath is more dangerous than the prevention of the stillbirth issues for that. Again, this is one aspect where we find that, yes, this is again the press people, how they circulate the news for that. And that is very important for us. And we should not fear that and run back in the and see. These are the events, both husband and wife, the couple of obstetricians and gynecologists in their nursing home have been heckled by the people. And this is the reward which is there for that. And therefore, this is a real issue of not only in medical legal scenario, but the mob violence is very, very important for that. So after these 2 episodes, 2 incidents which has taken place afterwards, let us find out the real cause of that and our management protocol in that, and what is the gray zone and gray areas for that stillbirth. Let us analyze in this episode 7, the stillbirth, the clinician's dilemma. It's absolutely a very common phenomena. The persons who are practicing obstetric, they must have experienced this day in and day out. And with the conceptual advances, with the technological advances and with the skill of the obstetricians also, still there is some gray area where we are not able to explain, and that is the area where science cannot explain. And therefore, my flow of events will be a prelude, a definition, prevalence, etiological factors, what are the risk factors, what are the classification, how you classify this, and most important is our clinicians' perspective, how you look at it. And management options is important for that. Situation analysis, then the second part important is the dilemmas. And these are all situation analysis and a clinician's dilemma from my end for that. And you must have experienced such similar incidents for that also. And last is the aftermaths, which I've already given a picture about the aftermaths and how to tackle the aftermaths also. I will give a brief review. And then at the end, what are the key points and what we take home message and implement it, practice it in a day-to-day practice for that. Now, obstetricians, we are a unique species. We are different from other faculties of medical sciences. There are two truths of life, birth and death. And we are the only category of healthcare provider who sees the two truths of life at the same time. The baby is dead, stillbirth, and mother is living. And in other cases, a maternal death and baby is living. And this is really important, and therefore, as a healthcare provider, as a man of science, in majority of the cases, we are finding a cause. But in few cases, we are not able to explain in terms of science. And that is the dilemma, and that is the real problem starting from that. And therefore, we as a healthcare provider, even if we practice, we're a strong practitioner of science, we're a strong believer of destiny. We have to be a strong believer of destiny when we realize this, when we cannot explain in terms of science for that. And that is the gray zone in the present status, which is facing us a challenge for that. Now, what are the aims of obstetric practice? There are two aims of obstetric practice. First, to achieve a delivery of a normal, healthy child with minimal physical discomfort and maximal psychological satisfaction for the parents. It's not only the physical discomfort, but the psychological satisfaction of the parents is most important with that born healthy child. Second important, to anticipate, to recognize, and to treat potentially abnormal conditions before significant hazards develop for the mother or baby. And this is why we enter into an area of preventive obstetrics. And these two are the main aims of obstetric practice for that. But believe me, these are some of the hard facts. Believe it or not, these are hard facts. Every birth is a medical emergency. Irrespective of whatever you say that it is a high risk case, it is a low risk case, every pregnancy carries some sort of risk. There is no risk pregnancy in that. And therefore, it is a medical emergency. Because many times everything is normal and all of a sudden veterinary and obstetric practice can come up, situation changing for that. And therefore, optimum obstetric result only on retrospect, not on prospect. Every patient must be asking you, doctor, how is everything? Whether I'm all right or not, my baby is all right or not during your antenatal checkup. And they ask whether everything will be normal or not. We can say that after everything, after delivery, we can say that everything is normal. But till date, everything is going on smooth. You cannot say that you are checking, having antenatal care at 32 weeks. You cannot for certain say that everything will be normal and you will have a normal, healthy child with a healthy mother for that also. This is the practice, obstetric practice. Another important thing to remember, most pregnancies, regardless of risk factors, result in a healthy infant. Even if the risk factors are there, most of the pregnancies result in healthy infants. But at the same time, perinatal morbidity and mortality occur in pregnancies with no identifiable risk. I remember few decades before, we were classifying and dividing into high-risk pregnancy and low-risk pregnancy. And therefore now There is no pregnancy which is no risk. And therefore, the risk categorization can help us in recognizing and taking a special care in prevention and prediction of that. But it doesn't guarantee that everything will be all right for that. New factors may emerge unpredictably. Say, for example, placental abruption, acute fulminating eclampsia, and there are many, many factors which can occur for that unpredictably at any point of time. And as an obstetrician, we are all human beings for that. And this previous obstetric experience of a human being like us affects the subsequent decision making. And this is called obstetric bias, obstetric emotions, and obstetric apprehension. Suppose you have bad experience in the last week of having a stillbirth, and then the next week also you find some of the adversities like a minimal elevation of blood pressure or even a pedal edema, or the patient says that I'm having a decreased fetal movement, you are worried about it for that. And this obstetric bias and emotions may lead to active mismanagement of that particular case for that. So don't relate that. You must know that whatever has happened, happened, and you learn from your own mistake and from the previous mistake for that. Pathophysiology of this stillbirth is extensively studied, but least understood. Remember that. And there are a wide spectrum of tests available in fetal surveillance. We have developed as far as technology is concerned. We have an extensive electronic methods of monitoring, computerized methods of monitoring the fetus in utero, in the antenatal fetal surveillance, intrapartum fetal surveillance, including the biochemical test, the ECG, the fetal ECG, and the CTG, and the different scoring system also we have it for that, aided with sonography with color Doppler is there for that also. But yet, no single or dependable test for that. And one practical thing I'm just telling you, fetal adaptation to stress is variable from one individual to other individual. And the stress is a labor events. And therefore, all of you must have observed that fetal heart during labor, 70, 80 irregular, deep meconium stent liquor, and normal delivery occurs. And of course, if you do a cesarean also, you deliver the baby, thick meconium stent liquor, and Apgar score is 8/10. Baby is crying well. On the contrary, absolutely normal, fetal heart rate, every parameters are normal on the gadgets, and baby is born with a depressed asphyxia. Apgar score is 2/10. This happens, therefore, fetal adaptation to stress, how it can adapt the stress of labor, of contractions, is variable from one fetus to other fetus for that. And that we cannot know. Now, there are many leading obstetricians, and I must quote one of the professor of obstetrics and gynecology tells, in my obstetric practice of 25 years, I have not faced stillbirths. What I will designate him? I'd say that either he is not practicing obstetrics or one of the greatest liars ever possible for that also. So therefore, even if we are knowledgeable, you have acquired very skill, important thing for that, but still this you must have faced in your life. If you have really done a obstetric practice, including me also, I can submit myself to tell that I have seen many, many stillbirths, and even with the existing knowledge and with the existing technology, I am applying for that. And that is the gray zone for which I have taken this episode as an important episode for the clinicians. Obstetrics is a bloody business. And when it culminates in adversities, it's a bloody business. Therefore, when you find a stillbirth, as a human being, as an emotional attachment, the parents are really depressed, grieved for that. And the parents or the party do not realize that the grief of the obstetrician is more than the patient himself. This is because we are also completely attached to the mother and baby for that, right from the beginning of antenatal care. They do not know that how much worried we are. And when we steal a stillbirth, every obstetrician must have remembered that the unhappiness starts when he sees the stillbirth. They cannot take a food, they cannot sleep well in the house for a few days till they recover, particularly for that. And this is the reality which the public do not understand for that. Now coming to the definition, there are a lot of controversies. Until today also, we are not able to reach at a consensus regarding the stillbirth definition for that. Simply literary meaning, when we find the child, baby is being born and no signs of life, is known as a stillborn. And that is very easy to say, and that is the fact for that also. But the terminology varies. The duration of gestation and the different terminologies are also changing also. When we were students, the classical thing is related to two main aspects. What is an abortion and what is an intrauterine fetal death. After abortion, the product is known as abortus, and after intrauterine fetal death, it is known as a stillborn. And that is related to the gestational age of viability. Age of viability is an important determining factor which divides for that. And for years together, we are teaching students that 28, including WHO also, they say that 28 weeks is regarded as the cutoff limit for that. Before 28 weeks, it has to be designated as an abortion. And after 28 weeks, it is designated as intrauterine fetal death. And after delivery, we call it as a stillborn for that. But now, the gadgets have improved in terms of neonatology. The intensive neonatal care, the NICU facilities have improved. So that 28 weeks, the age of viability, we can be able to survive extrauterine before 28 weeks also. So science is changing and we must cope with the scientific change, and therefore the babies who are born before 28 weeks also, if you can make it survivable with our efforts by the neonatal care, the age of viability cannot be at 28 weeks for that, and therefore globally there is a lot of change for that. This is also variable from developing to developed countries and the facilities of the neonatal care available for that. And therefore, there is a change in the gestational age viability for that and down to almost around 20 weeks. Globally, although there are various changes in the definition, some countries say 20 weeks, some countries say 24 weeks for that. But the fact remains that as we go stick to 28 weeks, the duration of gestation is important. As we go down 28 weeks, the birth weight is important for that. So birth weight remaining constant is 500 grams. So 500 grams, accepting one or two literatures which has reported 450 gram fetus can be survivable for that. But invariably 500 grams is taken as a standard all over the globe. If you see a global perspective for that, not only an Indian perspective. And therefore, this 500 grams is achieved around 20 to 22 weeks of gestation for that. So when we go down, the birth weight is important and we designated 500 grams is there, and therefore 20 weeks of gestation has been accepted now as the lower limit of this IUFD or stillbirth for that. So therefore, to give a clear message, I must say that from 28 weeks is the lower limit, 28 weeks of gestation till delivery is called a stillbirth. Whereas before 20 weeks, it is called a miscarriage or an abortion for that. That should be the clinician's objective for that also. Even if with the controversies and all that, let us have a clinical consensus on the clinician's perspective. We take it this particular entity for that. And now I've already told that IUFD after delivery becomes a stillbirth. Born baby born shows no signs of life, and therefore this has been divided long since. Also when we were students, we were being read and we are being asked by teachers, what is a fresh stillborn, what is a macerated stillborn. Fresh stillborn implies that a recent insult has taken place. Baby has died recently, that is within 24 to 48 hours. And before that, it is known as a macerated stillbirth. And therefore, we say that all antepartum stillbirth are macerated stillbirth, all intrapartum stillbirth are fresh stillbirth also for that. That is very simply identifiable and understood for that. And maceration is a physiological process of related to the tissue degeneration for that after the vital signs appear. So therefore, maceration means there must be some changes in the tissues of the baby for that. And that implies a duration, long-standing duration, at least more than 48 hours for that also. Now, fetal death, WHO in the CDC, and with the experts, they were confused about this definition for that also. But as the clinicians, we must stick to it. But there is a separate definition of fetal death by WHO at last, and which is being explained theoretically for that also. What is that? And let us, as a clinician's perspective, where is the problem, where is the challenges, and where is the controversy arising out of it also. So fetal death means death prior to complete expulsion or extraction from the mother of a product of human conception, irrespective of the duration of pregnancy, and which is not an induced termination of pregnancy. This death is indicated by the fact that after such expulsion or extraction, the fetus does not breathe or show any other evidence of life, such as beating of the heart, pulsation of the umbilical cord, or definite movement of voluntary muscles. Heartbeats are to be distinguished from transient cardiac contractions. Respirations are to be distinguished from fleeting respiratory force or gaps. The latter part is absolutely all right. Death signifies what? And therefore, this latter part is all right. But the primary thing is that earlier part, irrespective of the duration of pregnancy. Now we differ. We've already been convinced that before 20 weeks is miscarriage, and after 20 weeks is IUFD and stillbirth for that. Now, therefore, if you consider this definition, fetal death implies both miscarriage as well as intrauterine fetal death and antepartum death as well as intrapartum death, both fresh and macerated for that. This is one, of course, one aspect which continues with that, and there is a changeable, interchangeable, the change in the definition for that. So let us find out and discuss something about the issues and controversies for that. I've already explained about the lower limit of gestational age. And lower limit we must consider 20 weeks. We cannot say that miscarriage before 20 weeks and after 20 weeks is IUFD. We are convinced about it. When we consider the fetal death, the definition of fetal death, we may accept that is irrespective of the duration of gestation. But the lower limit of gestational age as far as stillbirth is concerned for that. And cutoff limit for fetal viability I have explained earlier, where 28 weeks was taken as a standard for that also. Again, I can say this, that we were teaching students and students also were replying. They were being convinced that 28 weeks for developing countries, 28 weeks for 20 weeks for developed countries. I think this is a confusion for that. Let us not go into details for that. Do we know that because of the advances in neonatal care facilities, the 28 weeks is no more acceptable, and 20 weeks we take it as a standard and a cutoff limit for fetal viability. There is certain for that also. And no more the developing and developed countries. Even the terminology of developing and developed countries has been changed to high income, middle income, and low income countries for that. It is the economic development of the country that determines this classification for that also, and we are all applying for that. Now, antepartum versus intrapartum death, I've explained that antepartum death we can have when we consider the stillborn baby, it can involve an antepartum death. And it can involve intrapartum death also, which is also not uncommon. And antepartum death gives rise to macerated stillborn. Intrapartum death gives rise to fresh stillborn. That is the only understanding and a clear understanding of this. The critical period of event is important. More important when dealing with the management of subsequent pregnancies after the stillbirth for that. And that critical period of event is very, very important for the clinicians for that. Whether that event leading to the intrauterine fetal death has taken in which weeks of gestation, at 32 weeks or 34 weeks or 36 weeks, that is important. And therefore, a clinician, while managing the pregnancy with the previous stillbirth, will always target for that critical period of event. That is more important and valuable. Otherwise, why it is important? Because many of the cases of recurrent phenomena is important for that. And there are cases where there is a recurrent fetal death at a particular gestation period for that also. We do not know many of the cases, the understanding for that, although there are some factors like a diabetes mellitus, GDM or hypertension could be associated. But in some cases, we do not know the cause for that also. Maybe that the placental, the fetal maturity occurs much earlier in some of the individuals, in these individuals, so that if you cross that area, I think gestational age, the placental insufficiency will be there and that will succumb for that. So this is important, and prediction and prevention. When we talk about preventive obstetric, in the second category of aim of obstetric practice, the prevention is important. And prediction is also important. That is only possible when we know 100% of the causes of this particular entity. If you know the causes, you can prevent it and you can predict it also. But I've already told, and you must have known, that there are cases where you are not able to explain. And beyond science, there is something with the existing improvement of the scientific development for that. So therefore, this prediction and prevention is important for a group of majority of the individuals for that. You can predict, but still there are some cases which you cannot, which I will show in a couple of slides for that. Coming to the prevalence of this entity, giving a rough statistics for that, basing on the CDC and NFHS data, the global data for that tells that 2.6 million stillbirths per more than 28 weeks globally. And 98% of all stillbirths occur in low or middle income countries, not developing countries, low and middle income countries, where 2% is only in the high income countries for that. And even in countries like United States of America, where they are developed much more than the other parts for that. See the figure, 24,000 stillbirths annually. This is very, very important landmark for that also. I must say, while telling with this prevalence, way back in 2014, the World Health Assembly formulated an ENAP, every newborn action plan, and the global target has been fixed that it should be reach 12 per 1,000 total births by 2030, 2030. And the interim figure and statistics were back in 2021, which demonstrated that out of these 139 countries have been able to fulfill the target and projecting to fulfill the target by 2030, 12 per 1,000 births. Whereas 56 countries, especially the low income and the middle income group, fail to do that. And that is the concern for that also. And therefore, the Stillbirth Collaborative Research Network, SCRN, has been developed by Kennedy Institute of Maternal and Child Health in United States, which has done an extensive survey globally about these particular figures for that. and they are trying hard to find out what is the cause, what is the problem of this particular entity for that. And in country like India, I know that there are some few people who are really concerned about it and formed a society of stillbirth. Very few. But I emphasize here that there is a need for stillbirth registry. The documentation is very, very poor in our countries. Globally also the documentation is very poor for that, but still it needs for stillbirth registry. Unless we document and data is there, we cannot do anything in action plan for that. Now, well, this last line I remember, stillbirth rate exceeding the infant mortality rate. We have been able to reduce the infant mortality rate considerably, but proportionately we are not able to match the stillbirth rate declining for that. And here is a figure we can say about the source is the National Vital Statistics System, the CDC and NCHS. The fetal deaths on one side and the infant deaths on one side. You see the fetal deaths has been categorized into two aspects, 20 to 27, early fetal death, and 28 weeks of gestation or more, late fetal death, a quarter each. Whereas the infant deaths under age 28 days, implying the early neonatal death and the late neonatal death, contributes to 35%. But what happens to the IUFD 28 days to under 1 year infant deaths? This has been dropped to 17.4. This is much less than the stillbirth rate for that, and that is also a point of concern for that. So more target has to be given to the reducing the stillbirth rate in addition to the infant mortality rate for that. This is again a very good source of CDC and National Vital Statistics, where the latest data I do not know, but this data I have recovered it, and this is a reflection. This is a changing trends from 1990 till 2006 and up till 2024 also. If you compare the two scenario, 20 to 27 early fetal deaths and late fetal deaths, 28 weeks or more, you can find in the 28 weeks or more fetal, there is a declining trend. And that is explainable in terms of an optimum neonatal care facilities available for that also. As the neonatal care improves with the NICU facilities, of course, it is explainable for that. But the plateau is maintained from 20 to 27 weeks for that also. It depends on few centers. There could be an erratic, very important, significant contribution for that. But overall, in the United States, it comes as a plateau for that. This is also a very important slide for the clinicians. I must say that this is a very important slide for the clinicians, and this is also a source of CDC and CHS. And this is a practical thing which all of you must have experienced. What is a safe period as far as the fetal death is concerned, and what is the unsafe period in which the fetal death is concerned for that also. If you consider from 20 weeks onwards till post-term, say 42, 43 weeks, the safe period, the fetus becomes safe from say 24 to 34 weeks of gestation. From 20 to 24 weeks, it is unsafe. We find more of deaths in between 20 to 24 weeks. See the graph. And see the graph after 32 weeks, it is gradually up and up. The mortality is gradually increasing for that. Not after 40 weeks. From 34 weeks onwards, there is a drastic increase in the death rate. And therefore, 24 to 34 weeks is an optimum period where we can rely that this is a period where the fetus is presumed to be safe and healthy for that. So as far as the mortality is concerned, more important is from 20 to 24 weeks, and more important is from 34 weeks onwards. till delivery for that also. And that is the period for that. And that's why the monitoring is more important in these 2 periods. If you want to prevent stillbirth, take it for granted that beyond 34 weeks, we have to monitor more efficiently for that if you want to prevent a stillbirth for that. Earlier, our monitoring is limited to only the weight gain, the blood pressure measurement, the fundal height which is erroneous, and the clinical estimate of the baby's weight and the liker. That's all. And of course, aided with that the fetal kick count. Now, we have gadgets available for viewing the interior and the fetal structure, function, and behavior of the fetus in utero by the ultrasound. And of course, with the color with the imaging sciences has developed, the man skill is developed, and the machines are also very important for that. And now machines, high-grade fetal machines are there, which is dedicated for fetal medicine. And more people are probably with 100% AI, artificial intelligence incorporated, that improves the resolution and many more things with the first recovery for that. And therefore, I can say that this has really helped us in improving the fetal outcome, the perinatal outcome for that also. Gone are the days when ultrasound was just starting. I am the witness, the evolution of this, particularly for last 47 years. At that time, ultrasound, indications of ultrasound in obstetric practice. Only one ultrasound is indicated, that is the TIFA, targeted imaging for fetal anomaly scan. Anomaly scan was there, and that too, we're not able to identify 100% of the anomalies or nearly 100% of the anomalies, but at least 50 to 60% of the anomalies we could be able to identify. And there is a debate between routine scan versus indicated scan. More than one scan. And now you see the change. Both in early as well as in late. Early scan at 11 to 13 week scan is important. And all of us, we know that not only it's for aneuploidy screening, but this particular dating scan as well as the predicting some abnormalities like a PIH is important at that particular, aided with some biochemical methodology. And therefore, the whole pyramid has been reversed. 11 to 13 weeks is important. Even on every pregnancy, if there is a problem, you can do more and more frequent scans for that also. And in some cases where previous history of ectopic, previous suppose a conception after the assisted reproductive technology, you can do an early scan for fetal viability. That is important. That is a different issue. But interval growth scan, more important is an interval growth scan in between 24 to 34 weeks of pregnancy for that interval growth scan, because the clinical parameters by fundal height and estimation of the fetal growth is suboptimum. And therefore, more frequently we must do it. And therefore, after 34 weeks also, till delivery, no more only one scan, depending on the patient's status regarding the fetal movement and the clinical deviation or fallacy, you can do more in fetal, I think, the ultrasound, which can help in improving the perinatal morbidity and mortality for that, and determining the timing of intervention or timing of delivery for that also. So this is a change. But what I mean to say with this particular slide, relatively safe period is 24 to 34 weeks. Before 24 weeks, there is a problem. After 34 weeks, there is a problem for that. After 34 weeks, more possibility of placental insufficiency, fetal growth disorders. And before 24 weeks, undiagnosed anomaly, structural anomaly or a genetic anomaly for that also could be additional factors for that. Now, these are the percentage of total live births and percentage of total stillbirth, where the same thing we find out that from 24 to 34 weeks, it is little less as compared to after 34 weeks and before 24 weeks for that. Now, let us find out the causes. Before enumerating the definite causes of stillbirth, let me give a message in the last column. 24%, a quarter, we do not find any cause undetermined. This is a point where there's a gray zone for that. In 3/4, we can find out a cause, but significant proportion, about 24%, we do not find out a cause that is called undetermined. Out of the cases where we get a cause, let us analyze one by one. The obstetric complications. These are all causes related to either maternal factors or fetal factors for that also. Fetal meaning there were both uteroplacental as well as the fetus. The obstetric complications like abruption, placental abruption, retroplacental clot formation, multifetal gestation, preterm premature rupture of membranes. These are all definite indication, definite causes of obstetric complications for that. Placental abnormalities when we find uteroplacental insufficiency and maternal vascular disorders. Subsequent to any maternal factors, maybe hypertension, maybe some of the thrombotic disorders for that also. But placental abnormalities are related. If you come to the fetal malformations, luckily by the good machines and man, the fetal medicine people could diagnose up to certainty about major structural abnormalities. But still, subtle factors are not being found out for that. Or genetic abnormalities are missed for that. We can find out the 13, 18, 21. But the other subtle abnormality of genetic abnormality as well as some sort of structural abnormalities are not being detected for that. Infection involving the fetus or placenta, and these are particularly the torch infections, the cytomegalovirus, the toxoplasmosis, parvovirus, all these are important for that, fetus or placenta. Or if there's a leaking, we find a chorioamnionitis giving rise to this particular problem. Umbilical cord abnormalities, these are all accidents. These are not diagnosed early for that. Umbilical cord abnormalities where we find a prolapse, cord prolapse in labor, early labor, and there are stricture. We do not know the cause why this stricture is there for that also. But cord entanglement we know. The nuchal cord is one of the common phenomena, but cord entanglement and true knot, cord avulsion, all these are some of the factors. Thrombosis are some of the factors in the cord abnormalities for them. So majority of the cases by ultrasound we can diagnose the nuchal cord and patients are afraid of it. But nuchal cord even once or twice around the cord is not a problem for that. But maybe that a long cord having entanglement at any point of time it must be a structure for that, an obstruction. Or a short cord giving rise to some problem. Or a true knot in the cord while the fetus is moving. This is the abnormality for that. And of course, the last but not the least, the abnormal cord insertion to the placenta. Either a filamentous insertion or some age insertion is there. So placental factors and cord factors are also important, particularly for some cases of unexplained fetal death, which can be known after that. Very important two things, maternal complications is a preeclampsia, hypertensive disorders of pregnancy affecting the fetus. And this is really a preventable entity for that. Preeclampsia and chronic hypertension. And medical complications we find two main important is a diabetes mellitus and antiphospholipid antibody syndrome, APLA syndrome and diabetes mellitus. And therefore, the recommendation now is all pregnancies should be screened for GDM. This criteria is important. All obstetricians are aware of that also. 75 grams, single shot, 2-hour post-glucose load. If more than 140 milligram, this is the cutoff limit for that. And therefore, when the previous history of diabetes is there or pre-pregnancy diabetes there, you can do a total OGTT for that also and treatment accordingly for that. Apla syndrome again is one of the syndrome where we get not only this recurrent phenomena could be there, not only in first the miscarriage, but also in the late fetal death also. But more important again, I must highlight about the undetermined group, which accounts for about 24%, a quarter of this. Now, this is a slide which gives rise to risk factors. The risk factors, these are all additional risk factors in total. Rest of the things risk factor which I have not covered. The prevalence, the estimated rate of stillbirth per 1000 births, and the odds ratio. We find that in low risk pregnancies also we find a significant proportion giving rise to this estimate of stillbirths. Hypertensive disease, I have already told about the chronic hypertension, pregnancy-induced hypertension. But here you find one thing in PIH. It is not related to only degree. We know that severe hypertension can be a cause of stillbirth. But even in mild PIH also, the odds ratio you find out in the prevalence about 5.8 to 7.7. And this has not to be dealt with the complacency for that also. One must be serious about it. Again, diabetes. And diabetes, therefore, has to be well controlled. And this is a situation where the medical nutrition therapy on one hand and the insulin therapy and the current developments of OHA in pregnancy, these three has to be weighed separately for that. And out of all studies, we say that insulin therapy is very good as far as the perinatal outcome is concerned. Even low dose insulin you give it, the perinatal outcome will be much more better for that. Another important is SLE, systemic lupus erythematosus, renal disease, thyroid disease, thrombophilia, and very common thing, cholestasis of pregnancy. Day in and day out, you must observe that cholestasis of pregnancy. Don't think it very lightly. In a patient where cholestasis of pregnancy, much more attention is given for fetal evaluation from time to time. Remember this, because the stillbirth is more commonly associated with the cholestasis of pregnancy. Apart from it, some socio-demographic factors, like individual factors like smoking, alcohol, obesity is important for that. Education, literacy status, and prior growth restricted infant and prior stillbirth are also very significant factors and the risk factors for that also. When there is a prior stillbirth, you must be very vigilant about it also. Apart from it, multiple gestations and of course the maternal age. Now with the changing socio-demographic, they marry late and conceive late, and therefore less than 35 years of maternal age are a significant independent factor for that. An independent factor for stillbirth is more than 35 and preferably more than 40. You can assure that this is a very high risk pregnancy for that. And of course, the racial distribution of black, non-Hispanic black in the United States has been studied clearly that they are more, about 2 to 3 times more prone for development of having a stillbirth than the whites comparison. So this is a racial difference for that. Now coming to the classification. We know that the classification are broadly classified as the clinicians sent it into antepartum and intrapartum. Antepartum is divided into early, intermediate, and late. If you consider the fetal death as a definition, we divide early fetal death, intermediate fetal death, and late fetal death. Early fetal death is less than 20 weeks. Intermediate is 20 to 27 weeks and late is 28 weeks. If we divide that less than 20 weeks, we take it as a miscarriage. And after 20 weeks, we have taken as a clinician's perspective. And for all, could be a consensus for that also. Then, again, the stillbirths have been divided into early stillbirth, 20 to 27 weeks. Late stillbirth, 28 to 36 weeks. And term stillbirth after 37 weeks. Again, I am telling you, as far as stillbirth classification is concerned, early stillbirth from 20 to 27 weeks, then late stillbirth 28 weeks to 36 weeks, and term stillbirth more than 37 weeks. Because we know that prolonged pregnancy is again a risk factor for stillbirth for that. So 40-41 weeks. When we talk about induction of labor, we consider that what is the upper limit. When we call it a post-term pregnancy is for more than 42 weeks. But remember, if you continue the pregnancy for more than about 42 weeks for that, that carries a much more serious risk of intrauterine fetal death. More so in Asian countries, more so in Indian, where it has been documented that Asian women achieve maturity 1 week earlier than the other counterparts for that. And therefore, we must not continue up to about 42 weeks for that. 41 weeks with a gadget is all right for that also. But if there is a previous history of stillbirth, you be long away from that particular event and try to deliver before at least in 38 to 39 weeks for that. There are a lot of things which consider that what are the probable causes, what are the possible causes. The definition, I couldn't understand the difference between what is a probable and what is a possible cause. So I did not mention about that. Now, as a clinician's perspective, I can again say that prediction and prevention. If you recognize the risk factors, definite risk for maternal, fetal, and socio-demographic factors, in those 75% of the cases, we find it less. In 25% of the quarter, we do not have any clue to that. And therefore, this is important. Then second important is you must evaluation of stillbirth. When a stillbirth has occurred, you must evaluate the cause of stillbirth as I have enumerated for that also. You can get a cause, you cannot get a cause also. One of the things which is very important in stillbirth is psychological aspects. Emotion is there with that. This psychological aspect of this couple is really very intense, and more so nowadays with the changing scenario, with the advanced age, with the small family norm, and with the quality of offspring. And therefore, we obstetricians are really at the helm of affairs with the Damocles sword hanging on us. We can explain, we can know the cause for that we can explain. And this psychological boosting of the patient after this stillbirth is very important. And this is a critical point, communicating the bad news. When we find that the fetal heart is not there, we subject it to ultrasound and we find the IUFD. Or even you have delivered it and it's a fresh stillborn because of some problem in the intrapartum period for that. This communicating bad news is really important as far as the aftermath is concerned for that, I am saying. The grief counseling, the behavior of yours as well as with the patients and the party, the relations are really important breaking points for that also. Either absolutely calm down or aggravating the situation for that also. The 5 types of grief, starting from denial, anger, bargaining, depression, and acceptance for that. That needs a time. And your attitude is also important. Your attitude of the staff is important for that also. When you explain an explainable cause, to some extent, they can realize. But when the 24% is about quarter of the cases, we do not able to find out a cause for that also. That is a great concern. How we have communicate the bad news for that. How we have to counsel that for that. And that will determine the individual nature of that, including the group, and in a phase-wise manner we give it. Don't prolong it. Earlier we were telling that you don't say the patient for that also. No, you must say the party, you must say the parents and the grandparents and the relationship of that, and try to explain the situation for that. But in some cases, they are not being convinced for that also, you are at a problem. Then the last part is the management options for that. Now the management options I've divided into 4 parts. Evaluation, again, evaluation of the stillbirth is important. Termination of pregnancy. You have to terminate the pregnancy for that on the route of delivery. And postnatal management. Then management of subsequent pregnancy after stillbirth is a different aspect which needs a more intricate analysis for that. Now, evaluation of stillbirth, again, whatever I told, just as a clinician's perspective, maternal evaluation, fetal evaluation has to be done. The maternal evaluation of the obstetric parameters, which are known causes and explainable causes for that, which I have already enumerated. And you must do some tests for that also, like a torch profile. The IgM is more important than IgG. APLA, both clinical as well as the laboratory criteria. Undiagnosed blood sugar status. We know that there are cases where the GDM can arise very late. Thyroid status, specific infections like the cytomegalovirus and other factors for that parvovirus, and others like a simple fever. Patient I have seen, all of you must have seen, that fever, the maternal, I think this is the cases where we find that the maternal conditions can be reflected on the fetus. Suppose there is a trauma, that is also one of the important. Road traffic accidents, that could be important for that. And moreover, we have experienced during 2019-20 the COVID-19 situation for that. How the COVID-19 is aggravated. Simple fever can be able to have an effect on the fetus. Long-standing shock, the simple diarrhea, dehydration and all that, the shock can affect the circulation for that also. So these are various other factors which takes into account and has to be evaluated and stillbirth for that. Fetal evaluation is much more delicate for that also. And people don't look at it. Obstetricians don't look at it. You just deliver it, throw it in the bucket for that also. I think this is incomplete evaluation of the fetus. Clinical examination of the dead fetus is important. Laboratory evaluation like blood, tissue, karyotyping, fetal autopsy, if the party gives a legal permission for that also. But invariably they don't give it. Many people do not opt for autopsy for that also. I remember I have given one thesis to one of my postgraduate fetal autopsy and find a very insignificant and remarkable causes can be attributable by doing a fetal autopsy along with the pathologist. And alternative to fetal autopsy, at least do a fetogram, MRI, fetal MRI and sonography, dead fetus, and the placental examination. Don't throw it in the bucket before examining in detail about this. This could guide you regarding some of the causes which can be really helpful for subsequent pregnancy. Clinical examination, see the placental inspection of the placenta, take the weight of the placenta, the thickness of the placenta, the photographs of fetus and placenta, the frontal and profile, photographs of whole body, face, extremities, palms and any abnormalities, and document findings and abnormalities. And obtain consent from parents for cytological specimens Obtain cytological specimens with sterile techniques and instruments for that. And preferably with the ringer selected. Acceptable cytological specimens, at least one, you have to obtain it. The amniotic fluid obtained by amniocentesis, at time of prenatal diagnosis and demise, which is rarely being done. Placental block 1 × 1 centimeter taken from below the cord insertion site on the unfixed placenta. Umbilical cord segment of about 1.5 centimeter. And the fetal tissue specimen. The fetal tissue specimen, don't take it, many people take it from the skin. Skin is not recommended. The costochondral junction or patella is the ideal places where you can send the fetal tissues for that. And place specimens in a sterile tissue culture medium of lactated ringer solution and keep it at room temperature when transferred to cytology laboratory. And if the fetal autopsy, you got a consent, parental consent, fetal autopsy and placental pathology and a whole fetal X-ray has to be done. If no consent is given, then the placenta alone, send the placenta for only the pathology for that. And this could be a genetic analysis for that also. And then now the microarray techniques have been there, an ideal technique which is replacing all other previous techniques for that in genetic analysis. This is a brief outline of the clinician's guideline for estimating approximate time of death prior to delivery, which I mean to say difference between the fresh stillbirth versus the macerated stillbirth. Estimated time of fetal demise prior to delivery you can find out by observing the fetus. If it is a brown or red discoloration of the umbilical cord or discommission more than 1 centimeter, you can say at least 6 hours gap is there. Discommission of the face, back and abdomen at least 12 hours. Discommission more than 5% of the body or at least more than 2 body zones at least 18 hours. Skin color brown or tan at least 24 hours. And mummification, reduced soft tissue volume, lethargy, skin, deeply brown stained tissues at least 2 weeks for that. Now, you have diagnosed that this is a intrauterine fetal death. And now what to do? Termination of pregnancy, there is no other way for that. But when you do a termination of pregnancy, the timing of termination, whether there is a place for waiting policy versus active intervention, whether the route of delivery, what is the route of delivery, what are the methods of termination for that, and indication of cesarean section. Now, waiting policy versus active intervention. Waiting policy, if you wait, there is no harm. And 80% of the cases do have a spontaneous onset of labor and expelled spontaneously by vaginal route if you wait for 2 weeks. So within 2 weeks, 80% will have that. And if you wait for 2 weeks also, the probable complications which is in your mind of development of DIC is minimal. You rarely will obtain it for that. Prolonged retention of more than 4 to 8 weeks, 2% will develop DIC for that. It's overemphasized for that. But main problem is the psychology of the patient. In the current status, no patient and a relative will want to wait for 2 weeks with that trauma in the mind for 2 weeks for that also. And therefore, active intervention is preferable in majority of the cases for that before the clinicians for that. And when you want to have an active intervention, route of delivery, first priority is a vaginal delivery for that. And route of delivery should be aimed at vaginal, not by operative intervention. And therefore, the methods of termination of pregnancy is important for that. Of course, indication of cesarean section, yes, it is there for that also. Say, for example, it is a transverse line. It is a complete placenta previa, completely encroaching the whole of the internal os. And these are the cases where cesarean section is absolutely essential in a dead fetus. and failure of induction. If you failed, you have to resort to an indication of cesarean section for that. So these are some of the indications. You can say placental abruption. You first try with that vaginal delivery, and majority of the cases it will be successful for that. But placenta previa, major degree of placenta previa, I think you have to do a elective cesarean section for that, even if it's a dead baby for that. Now, I've told that always plan for the vaginal delivery. What are the methods of termination of pregnancy? The methods of termination of pregnancy could be medical methods, starting from oxytocin infusion to different forms of prostaglandins, and mechanical methods. The methods of termination by oxytocin is limited where the cervix is favorable, and when the cervix is not favorable, the oxytocin induction becomes a failure for that also. And therefore, if cervix is unfavorable, the prostaglandins, preferably the misoprostol, are the drug of choice for that. And misoprostol, you can give if 25 to 50 microgram misoprostol at 4-hour interval, and that will yield a better result for that also. And preferably, you can add 200 microgram of mifepristone prior to that, at least 12 hours before, and then start misoprostol. That will enhance and reduce the time interval for that. These are clinical observation for that. Now, before misoprostol was available, we are using the cerviprim, cervical, inside the cervix. But now, the cervidil, the vaginal prostaglandin PGE2 is also being used, and that if there is a hypertonus, you can remove it with the thread for that also. Cervidil. Suppository, vaginal suppositories for that also. And this misoprostol vaginally or suppository, you can give it to cervidil, is the method as far as the medical methods are concerned. These other methods are mechanical methods, is a Foley's catheter as a mechanical. Along with it, you can give an extraamniotic installation of about 100 to 150 ml of normal saline. That acts much better than simple Foley's in dilatation of the cervix for that. So this is also a very good option in non-favorable cervix, where you can use the Foley's catheter with the extraamniotic installation of normal saline for that also. Now, after that, the postnatal management. Again, I can say the postnatal counseling for couple and family is important for that also. The grief counseling is important, and methodology of bereavement lessening is important for that also. You can find out the possible cause for the fetal demise, they can explain it. But if you don't find, I think there is a problem for that also. And what are the risks in next pregnancy, they will ask. Subsequent risk in the pregnancy for that. If you find a cause, it's all right for that. Otherwise, the next pregnancy will require more of particularly aggressive time-to-time investigations and management for that also. Along with that, suppression of lactation by cabergoline, Rh negative women, the anti-D immunoglobulin for that also, and follow-up visit you must give. Before follow-up visit, plans for future pregnancy for that. They'll ask, when I can plan for future pregnancy for that also. It depends on the patient's age, on the patient status for that also. But minimum 3 months is a bereavement family, and recovery of the patient is important for that also. And if there is a cesarean section is there, you have to wait up to 6 months for that. Don't wait much more for. Many people prefer to wait for 1.5 years. No, you must say, because the baby with the trauma will be relieved for that much earlier for that. And contraceptive advice for those period is advisable. If it's short term, you can use the mechanical methods for that also. Otherwise, you can give a COC for that. Now, much more important in management of subsequent pregnancy after stillbirth. What you do it. Before that, You ask for a preconception or initial prenatal visit. Then first trimester, second trimester, third trimester. And more important is the route of delivery and a live baby. So preconception or initial prenatal visit, again, you have to again review the detailed medical and obstetric history. Evaluation and workup of previous stillbirth, again, you just have a look. Determination of recurrence risk. If you find a recurrence risk factor, you find out. And along with it, general advice regarding the smoking cessation, weight loss in obese women, genetic counseling if family condition exists, diabetic screen is important. Thrombophilia workup should be done for that, antiphospholipid antibodies. And then support and reassurance is always, in all visits, you must give it for that. And that will boost her in terms of psychological phenomena. First trimester, when it comes to UTP, positive and first trimester. Apart from viability scan, dating ultrasound and screening the NT. At 11 to 13 weeks is important for NT scan. And that is important. An NT scan with double marker or pentamarker. In addition to it, the PLGF will give it some information regarding the probable risk of PIH, developing PIH with the color Doppler also. But now, two things, new innovations are there. NIPT and NIPS. These are all same. NIPT, non-invasive prenatal test, and non-invasive prenatal screening is all important for that. Gone are the days when these tests were very costly. Starting, I have seen the evolution. About 60,000 per test has been dropped up to 32,000, then dropped up to 15,000, now 10,000, 12,000, all of the country in the Indian scenario. My own views, I can say, I may be wrong, I may be right, I don't know. But my policy, initially I was doing the NT scan with the double marker. And if the double marker could not be done, patients present late, at least a quadruple marker at 16 weeks doing a scan. And PLGF, of course, we do it for that. For aneuploidy screening, not for preeclampsia prevention and prediction, it is for aneuploidy screening. This is important, NIPT and NIPS. All the chromosomes are there. And initially, over years, my clinical exposure and my observation, I did about 1,000 cases. Out of 1,000 cases of NIPT and spending 10,000 rupees or 12,000 rupees at that time, I find only 18 cases yielded positive result. And this positive is only 13, 18 and 21 chromosomes, not in other chromosomes further. So I contacted my genetic lab. I want only 13, 18, 21. Why every chromosome has to be done? And you can reduce the cost for that also. And the screening could be done NIPS. And now, for the last 2 years, I am doing NT scan and no double marker. When there is a history of preeclampsia, I am doing the pentamarker test or PLGF. That's all. But NT, I am skipping even double marker. People have skipped a triple marker. That's all right. I'm skipping double marker, quadruple marker, triple marker. Why give 2,500 rupees for the double marker for that extra? The cost factor is a real problem in a country like India. And therefore, if all obstetricians will do NIPS, I think the cost should be reduced for that. I contacted the genetic. I told that yes, all my cases will routinely I do that, and I do it with 3,500 rupees to 4,000 rupees. For the last 2 years, I'm doing it, and really I'm very happy for that. And all the obstetricians will have the same concept. It will be done with 500 rupees or 1,000 rupees also, less than the other procedure for that. It depends on the number. So what I mean to say, that NIPS is a screening test. It's not a confirmatory test, I agree. But the accuracy is much more than the biochemical test or the combination or integration test or that. And therefore, this is important. And again, I say that first trimester, again, you give a support and reassurance for that. Second trimester, fetal ultrasound anatomic survey at 18 to 22 weeks of gestation, the TIFA scan by a good fetal medicine specialist, or if you are an obstetrician and trained in that particular aspect, employ a good machine for that also. Dedicated machine for fetal medicine is available now. You can do it with that. And structural anomaly can be done with that. You can find out, in addition, genetic sonogram or sonographic pointers of genetic abnormality. So soft markers, you can find it out for that also and corroborate for that. And of course, fetal echo is a special entity which is not being accurate in early weeks, like 22 weeks for that. Because 60% of the cases we can diagnose, but rest are missed, and do that fetal echo around 24 weeks for that also. Before 20, after 24 weeks, there is no valid reasons for doing it for medical legal purpose. And if the early scan has not been done, you can resort to maternal serum screening like quadruple test as a screening test for that. Again, support and reassurance has to be done. Third trimester, ultrasonographic screening of fetal growth restriction after 28 weeks in correlation with the clinical parameters. You do it, you cannot ignore the clinical examination for that. So third trimester, because we know that the fundal height and other parameters, there is an interpersonal as well as intrapersonal variation for that. And therefore, more and more frequently ultrasound screening of fetal growth restriction after 28 weeks for that. Apart from interval growth scan, if you find a growth restriction, you have to do more frequently for that. And you cannot ignore the kick counts, and kick counts also very important, 28 weeks, which is very important. Antepartum fetal surveillance starting at 32 weeks of 1 to 2 weeks earlier than the prior stillbirth. When the prior stillbirth, that's why I told what is the cutoff limit, what is the critical point, critical period in which the fetal, that point is important. And 1 to 2 weeks before the duration is more important. You have to be very more vigilant about it. And that maybe recording of the blood pressure, finding out an exclusion of the preeclampsia, or a diabetic screen or a thrombophilias screen. This sonographic estimation of the fetal growth periodically is very, very important beyond 32 weeks. Because this is typical, I told, that 34 weeks onwards is more important for that. More frequent sonographic examination could be employed for that. And of course, support and reassurance. Now comes route of deciding for the route of delivery. Now, with the liberalized indication of cesarean section, and more so in the case of previous stillbirth, liberalized indication will be justifiable to improve the perinatal outcome. In the era when we say that try to reduce the rate of cesarean section, increasing cesarean section, this is something different for that. But still there is a place for induction of labor and vaginal delivery. So this, what is the timing of that? Don't continue it. Even at 38, 39 weeks also, you continue, you terminate the pregnancy. If there is a diabetes mellitus, you don't continue up to beyond term. If there is a PIH, don't continue. Even at 36 weeks also induce it if there is a PIH for that also. So earlier delivery as per the maternal and fetal parameters is important. Below 39 weeks also, you have to do an early delivery for that. And of course, liberalized indication for cesarean section. In the era when there is a debate of reducing the rate of cesarean section, I think this is an era, this is a case where a previous stillbirth at term, the Damocles sword will be hanging on your head, and liberalized indication for cesarean section, I will support for that. Now, ladies and gentlemen, the last part, let me brief about the situation analysis of my own cases, which all of you must have similar observation for that. Let us introspect, scientific analysis, and then action with confidence. This is the problem 1, priming gravida at 28 years, married 5 years, obese. It is a booked case, normal dating scan, first trimester scanning normal, including the NT scan, TIFA normal. Then the patient vanished. She presented at 37 weeks. After 20 weeks, there is no antenatal checkup for that. And 37 weeks. And most probably this is during the COVID time. And she was doing the ultrasound somewhere. And they say that everything is normal without any checkup. But presented at 37 weeks, unable to appreciate the fetal movement since 24 hours. When I examined, blood pressure was 140/100, mild pedal edema, urine albumin double plus, stress, uterus 32 weeks, vortex 5/5, FHS absent, sonography, intrauterine fetal death, and oligoamnios. Now, what's your approach? What's wrong in this case? She didn't present to the obstetrician, maybe because of the COVID situation for that. I accept. She's undone. And only ultrasound doesn't serve the purpose. She may have a hypertension development before that. And what's wrong? What's your approach for that? And what are the lessons learned? So the message here, importance of ANC in late pregnancy. The place for interval growth scan is important. More frequent monitoring, as I told, 34 weeks and onwards, the risk of the fetus is much more for that. So this is lacking, importance of ANC late pregnancy. Role of interval growth scan or BPP. Hypertensive disorder of pregnancy is a significant cause. This is certainly due to hypertensive disorder of pregnancy. And early recognition and intervention would have prevented this entity. And this is a tips for subsequent pregnancy. We have known the cause. This is explainable cause for stillbirth. And we must tackle that. Problem 2, third gravida, abortion 2 at 28 weeks. Both spontaneous first trimester abortion at 10th week. Built average, pallor nil, mild pedal edema, blood pressure 150/102, urine albumin double plus, and uterus is 24 weeks. Date 28 weeks. FHS not localized, sonography IUD. Now, we have done the management route of delivery, termination pregnancy was done by vaginal route by misoprostol. An expelled macerated fetus with a deep meconium stain liquor discharged after 48 hours and normotensive on discharge. Now, what's wrong in this case? Let us analyze. Let us introspect what investigations should you suggest and plan for next pregnancy for that. This is the case. Think of Apla syndrome. Apla syndrome, there are clinical criteria as well as the laboratory criteria. The clinical criteria is much more important. And one definite criteria, clinical criteria is there. And the concept of preeclampsia, long before term. We know earlier we were reading that preeclampsia usually occurs in third trimester. But these are 28 weeks. But preeclampsia developing long before term in absence of multipetal gestation and molar pregnancy, one should suspect first in Apla syndrome for that. Think of Apla syndrome in that particular cases for that. So these are the cases where IUGR occurs and IUFD occurs. Now, we have seen some cases of IUGR long before term, early weeks IUGR long before term, and leverage is a case of Apla syndrome and treated with aspirin and heparin. Not significant perinatal outcome will be there for that. But these cases, in the next pregnancy, you start aspirin and heparin right from the early pregnancy. As soon as the pregnancy is diagnosed, you start aspirin and heparin and continue it. It will have a very good perinatal outcome for them. So this pregnancy you cannot save even if they are IUGR, but the next pregnancy definitely you can save the baby. And here with the previous stillbirth, think of this and remember in the next pregnancy, as soon as the pregnancy UPT becomes positive, aspirin and heparin has a rewarding results for that also. Now when to start, what dose and how long? Now, the recommendation of aspirin is periconceptional. Before pregnancy, you can start aspirin. And the standard recommendation earlier in the textbook also, add heparin, either a conventional or low molecular weight heparin, when the fetal heart is appreciable by sonographic demonstration of cardiac activity, you add heparin for that. No more. Now you start from the beginning, and even the vascular theory and vasculogenesis attributable for APLA will match it and continue the survival of the baby right from the early phase for that. So you start it as soon as the pregnancy, no more the cardiac activity. What dose? If it is a low molecular weight heparin, I think commonly used 24 hours. 40 is enough, 40 units every 24 hours, or even 48 hours also. You can make it up to about 34 weeks for that. Only in cases where there is a thrombophilia or deep history of deep vein thrombosis, you continue till labor. Otherwise, you stop as soon as the fetal likelihood of survival will achieve, not at 37 weeks, at 34 weeks, majority can be able to survive for that. And up to 34 weeks, you continue. Otherwise, you continue more till delivery, and after that also, if you find a thrombophilia, known hereditary thrombophilia, history of deep vein thrombosis, you continue it after that. Otherwise, routinely, you stop it at 34 weeks. This is another. Gravida 4, para 2, abortion 1, leaving 0. Book case. First is a spontaneous vaginal delivery, early neonatal death due to birth asphyxia. Second, lap salpingectomy for disturbed tubal pregnancy, right? Third was again an IUFD at 32nd week. Now presented with one episode of bleeding baby at 36th week. She was having a regular checkup with this bad obstetric history. So she presented with one episode of bleeding baby at 36th week. Till that time, everything was normal. And we examined, find blood pressure was 140/94. 2-hour PGBS normal. Sonography single live fetus 35 weeks. Vertex estimated birth weight is 2.7 kg. AFI is 9 centimeter optimum. Placenta upper segment normal. And collar Doppler was also done, it's normal. And therefore, she was admitted for 24 hours, discharged after 24 hours of observation, but advised to report after 1 week. We have decided that after 1 week, we should have an active intervention for that. But presented after 4 days with second episode of severe bleeding PV, blood pressure was 150/100 millimeter mercury. Uterus tense, tender, absent fetal heart, sonography IUFD with retroplacental absorption. ARM was done. Fresh stillborn male fetus of 3.2 kg delivered with retroplacental clots. Now, what's wrong with the patient or with the physician? It's wrong with the physician. I take the blame. That is important. It is a fault of the obstetrician. The patient has given an alarm signal with bad obstetric history, with no living issue. At 36th week, the obstetrician was complacent by finding out by sonographic evidence of everything normal, collar Doppler normal, AFI 9 centimeter, and fetal movement is normal, and advised for 1 week. Retrospectively, if we find it, I think if a delivery intervened at 36th week onwards, the fetus could have been saved. So the message, no complacency in obstetrics. Given a alarm signal, sufficient warm signal, alarm signal, case of bad obstetric history, mild hypertension 140/94 with first episode of bleeding. 3 alarm signal are there, and the obstetrician become complacent with that. So early intervention could have saved. And here, such type of patients, don't leave it. You have to do an early resort to cesarean section or perinatal. Problem 4. 35 years, gravida 2, para 1, first spontaneous vaginal delivery. Consider following investigation for second infertility PCOD. Clomiphene citrate was given, plus metformin was given. It was a booked case, but presented at 38th week with loss of fetal movement for 24 hours. Bill to delivery is normotensive, uterus storm size, vertex, FHS not localized. Sonography, single dead fetus at 38.6 weeks. A5 14 centimeter. Fetal weight is 3.8 kg. Fasting blood sugar 146 milligram. PPBS 248 milligrams. Now you see this is a case for that. A case for PCOD. Now, the evolution of management of PCOD in terms of metformin was there. Metformin was indicated for PCOD along with ovulation induction. And initially, the recommendation was there that as soon as the pregnancy is diagnosed, stop metformin. Then these cases, when they followed, increased miscarriage rate over there. Then they thought that metformin, the second recommendation was that metformin is relatively safe as far as the teratogenesis is concerned, and it should be continued up to about 14 weeks for that, and then stopped. Then these cases were followed up. If I stop metformin at 14 weeks, they are more prone to develop GDM in future. And then now, the current recommendation of PCOD and then pregnancy, continue metformin till 14 weeks for prevention of miscarriage and continue metformin till term or till delivery for GDM prevention for that. And that is the recommendation for that. But this is a case where it was stopped and routine screening was not done. And this is wrong in this case. And how this is an avoidable, this is a preventable case for that. So GDM is the commonest cause of stillbirth, remember this. And therefore, routine screening is mandatory, and all obstetricians are convinced that DIPSA criteria, GCT, 75 grams, one shot of blood glucose estimation is absolutely important. And when there is an additional thing, you can repeat these procedures for that also later, about 8 weeks later. Or if you find that there is a polyhydramnios, more suspicion that could be there, and you can continue that. So routine screening is mandatory. Optimum control is necessary when there is a GDM. I have already told that no maternal nutrition therapy. In a borderline case, maternal nutrition therapy MNT can be available, but majority, the perinatal outcome is good by insulin. Role of metformin as a prophylaxis, you can give it, but insulin is ideal for improved perinatal outcome. Even if with the small doses also, with insulin, this is there for that. And therefore, with the liaison with the endocrinologist and obstetrician, this patient should be continued that till term, and then appropriate delivery, either a cesarean section or induction level, to be continued. Primary gravida, booked case, regular ANC, presented at 38th week with loss of fetal movement since morning. First trimester screening normal, everything is normal. Very sincere patient, dating scan, TIFA, interval growth scan normal, a regular checkup, all investigations have been done. Last week sonography with color Doppler normal with BPP, biophysical profile, and normal blood flow, GCT normal, euthyroid, all investigations have been done. And on examination, we find normotensive, uterus tense, uterus storm size relaxed, FHS not localized, cervix long, os closed, normal discharge. And here we couldn't find any cause for that. And sonography demonstrates IUFD at 38th week. Vertex, estimated fetal weight is 2.9 kg, AFI is 10 centimeter. So what's wrong in this case? Neither the patient nor the obstetrician has taken any complacency attitude in investigations and treatment. But in spite of all this, I think what's wrong in this case and route of delivery. I think this case is a brighter example for this quarter of cases where no identifiable cause is found for that. Undetermined cause, and this is an unlucky patient, and I'm an unlucky obstetrician, and therefore I must analyze lady, luck, and labor. There must be some cause which our minds are not able to pick up, particularly for that. And on delivery also, we must find out that what could be the cause. Could be a cord accident, could be a subtle, I think, retroplacental clot or a placental abruption for that. But in spite of all these, if everything is normal, we attribute to this particular case as undetermined. 28 years primary gravida, conceived following ovulation induction, twin gestation. Regular ANC, interval growth scan at 34th week revealed twin fetuses. First living breech presentation at 34.2 weeks with satisfactory biophysical profile. Second, IUFD at 31 weeks. It is not an uncommon phenomenon, uncommon experience. It's a common clinical scenario with that. And this is a twin fetus with single fetal demise has been categorized as for which trimester that happens for them. If it is before in first trimester pregnancy, majority of the cases will not have any problem. This is a vanishing twin syndrome and this will be collapse for them. It is not going to affect the other fetus, neither the DIC for them. Then the second trimester up to 28 weeks. Fetal demise, this if it is a monochorionic is more possible happening for that. And this particular case, the dead fetus, the living fetus is liable to have some neurologic developmental delay. Ototoxicity or neurotoxicity could be there in this category, particularly for that. And that termination of pregnancy is a very crucial decision for this category also. The third category is at 28 weeks and above, like this particular case. We presume that we cannot deliver it immediately at 32 or 34 weeks of gestation because of the fetal maturity. But at the same time, the possibility of DIC development, risk of DIC is there with our mind. So how can we solve it? Remember, DIC, I've already told that long periods of retention is a possibility for development of DIC. But here, the possibility of DIC, because we have to wait for another, say, three weeks for that. Within that, after 2 weeks, the possibility of DIC could be much more for that. So this is a theoretical possibility for that. And next is there a risk to the living fetus? Like I told that in second trimester, there is a risk for the second fetus in neuro or ototoxicity for that. But here it doesn't happen. The only possibility is a theoretical possibility of DIC. And therefore, what other investigations should you suggest and what is your obstetric management? So twin with single fetal demise is not uncommon. And I have already told fetal demise in different trimester variable obstetric impact. Like first trimester vanishing, no impact. Second trimester, it has an impact on the living fetus. Third, risk of DIC. And it cannot be ruled out in prolonged retention of the fetus. If it is diagnosed at around 30 weeks, you cannot terminate. You have to continue up to about another 4 weeks for that. Minimum 34 weeks for that. An early termination of pregnancy, not compromising fetal maturity, is the preferred treatment for that. And even if you give an antenatal glucocorticoid and deliver it around 34-35 weeks for that, that could be a better solution for that. Problem 7. Primary gravida, 32 years conceived following investigation for primary infertility, 8 years. IVF conception. Husband is an IPS officer, wife is a journalist. Terrible combination. Twin pregnancy, IVF pregnancy, irregular ANC, had bleeding at 11th week, treated conservatively, NT, triple marker normal, TIFA normal scan, normotensive, admitted with preterm labor at 31st week. Hospitalized, given betamethasone, nifedipine, rest, repeat sonography, revealed normal biophysical profile, discharged after 1 week, after 32 weeks, counseled to undergo elective cesarean at 36th week, readmitted after 2 weeks, that is when at 34th week, with an episode of mild bleeding PV. BP was 140/90, uterus tense, tender, FHS not localized, no active bleeding PV, urine albumin nil. On sonography, twin fetuses at 33.2 weeks and 34.1 weeks, IUFD, both vortex, estimated birth weight is 2.2 kg and 2.4 kg. And placenta upper segment, no evidence of retroperitoneal clot. Now, let us analyze for that. The patient vanished for 2 weeks and we have advised for 1 week review, and that has saved us. Because he has vanished for 2 weeks and then presented with IUFD for that. And that has really saved us. But technically, we cannot deliver it at 32 weeks routinely in all cases for that in IVF. Only with 140/94 millimeter mercury with antihypertensive given and close observation, and that to a color Doppler and ultrasound is normal. So what wrong with the patient? Patient is little callous at the fag end. And what wrong with the obstetrician? I think 36 weeks, these cases with the alarm signal must have been delivered at 34th week because the betamethasone has already been given for that. And this have been done to save the baby's life. And what next? The next is again a message, a big question mark. IVF pregnancy is locked, but to have a baby is destiny. Even with best practice, such things can happen. Prevention and prediction is $1 million question. Early intervention is justifiable, but only on retrospective thought. Counseling, communicating bad news after effect. And next pregnancy is a possibility. Outcome is a real question mark. This is another case, G3P2L1. Previous 2 CS. First was cesarean section, torn male baby could not be revived. Birth asphyxia. Second LACS elective. Female baby of 2.9 kg living 6 years. Conceived following investigation for second infertility. Tubal cannulation has been done. And then she conceived with the previous 2 CS with 1 living issue. Regular ANC. And decided for elective cesarean section at term. And at 38th week, we have decided on 18th February, no risk factor, normal biophysical profile, color Doppler normal. And they have decided on 18th February. But subsequently, patient relations opted and wanted to change the date and opted at time advised by the Baba. They consulted 18th is not a suitable date, do it on 20th of February, 2 days. Shift. And I happily agreed because the 2 days is nothing because there is no technical reasons for that. On 19th February, patient had 1 episode of mild bleeding PV, uterus relaxed, normotensive, FHS not localized, sonography demonstrates IUFD. This is the Baba's result, Baba effect. What's wrong with the obstetrician? And what's wrong with the patient? Technically, the obstetrician is not at fault, but the only fault is that he has agreed to the Baba. As this is an accident, and I did a cesarean, and I find both small retroperitoneal clot as well as a true knot in the cord. True knot in the cord was found, and that has been the cause for that, which can be an accident. But this accident can happen, but it's coincidence which is more painful for the obstetricians. It is an accident, but coincidence. And decision versus deviation, then I thought. 18 July, if I would have done it, 18 February, if I had done it, pending for 20th and 19th, the incidences took place. Decision versus deviation could be there. Most probably, above Baba, the God is envious and very disagreed or envious on the Baba, and that's why he became angry, and that's why the the cord accident has happened for that. But accidents are decision versus deviation, and from that day onwards, I never change if I decided for that. 28 years primary gravida, 32 weeks gestation, regular ANC, presented with acute pain, abdomen, and loss of fetal movement. On examination, tachycardia, shock, BP was 90/50, pallor plus, for abdomen, tender lower abdomen, uterine contour not identified, FHS not localized, cervix long was closed. Sonography, single intrauterine dead fetus of 31.5 weeks. Estimated birth weight is 1650 gram with free fluid in peritoneal cavity suggestive of blood. And immediately it's an emergency and diagnosis of rupture uterus, silent rupture uterus was done. A clinical diagnosis and intervention, immediate intervention. So diagnosis as silent rupture of uterus, there is no risk, there is no scar. Plan for immediate laparotomy with arrangement of blood. On laparotomy, I find extensive hemoperitoneum with fundal rupture in midline. Midline, there is a rupture with active bleeding from the edges. Fresh stillborn male baby delivered through the wound along with afterwards. Uterus repaired in layers with hemostasis. Peritoneal toileting done. Discharged on 5th post-op day. So what are the clinician's dilemma? Cause of silent rupture. It's not very common, but cause of silent rupture. The things you must analyze that what should be the cause of rupture. Undisclosed, say perforation, fundal perforation before that is one of the cause for that. That's a weak point. Or you have done a septoplasty or a gynaecology, histoscopic, and then pregnancy has occurred. And fundal area of the muscle is thin, there could be explained for that. Or you have done a myomectomy in the fundus and that could be explained for that also. But silent rupture without anything can be possible. And this can be explained. There is a midline in the fundus in the midline. That suggests me for embryological correlation of the two halves of the Mullerian system uniting in the center. And we have seen many cases where we do a laparoscopy, we find the union and the line in between two things for that. And that could be a weak point giving rise to silent rupture for that. If there's a cause, we can explain, but here it is not explaining. So after the event took place, immediate diagnosis and active surgical intervention is there. Don't wait time for the arrangement of the blood. Immediately you intervene for that. And for the future pregnancy, you have to repair it, optimum repair of uterine wound. Very good layered repair you must do a uterine wound for that, keeping in mind the future outcome of the pregnancy and subsequent risk of rupture is there, but how it can be minimized. A good deposition is important for that. And subsequent pregnancy issues, interval. You must give a gap at least 6 months to 1 year for that. And in ANC, I have a couple of cases regarding this particular case and similar cases where ANC specific points, you target at which point, 31, 32 weeks, and when the uterus enlarges, 36 weeks is the part where the uterus expands maximum for that. But don't wait for that. At least you give a steroid and deliver it at between 32 to 34 weeks in this type of cases. And specific points you tell. Any point you find significant pain, you just admit the hospital. And elective says the timing is important for that also. And with betnosol, do it at that particular timing for that. Problem 10. 32 years, primary gravida at 34 weeks. Leaking membrane since 48 hours. Referred from CHC with features of intrauterine fetal death. On examination, it was afebrile, vitals was normal. Uterus 30 weeks, relaxed, no localized tenderness, FHS is absent. Cervix half an inch long, was closed, dirty discharge clause. And sonography demonstrates IUFD at 33 weeks with nil lichen. What's your approach? This can be explainable. That prolonged leaking, PPROM is definitely a cause with that, aided with or without chorioamnionitis. So, the clinician's dilemma, long-standing leaking, more than 48 hours. Possibility of chorioamnionitis could be there. And you must know in the CSs whether there is a previous attempt of induction and methodology of induction there, so that your route of delivery can be planned for that. So what is the plan? Screening for infection and antibiotics, cover broad spectrum antibiotics, and no intervention has been done in CHC, therefore induction of labor with misoprostol, targeting for vaginal delivery. And with misoprostol 25 micrograms 6 hourly 4 doses has been given. Failed induction, no pain. So LSS was done, macerated fetus of 2 kg delivered post-op on event. So the priority is that you must go for a vaginal delivery, attempt for a vaginal delivery by induction of labor, because the presentations and positions are normal and there is no chorioamnionitis. And therefore, if the induction of labor fails, or if there is a malpresentation, or if there is a previous multiple scars in the uterus, or some of the cases of acute chorioamnionitis, you have to deliver it by cesarean section, even with the dead fetus. So PPRM not uncommon clinical scenario. Short-term waiting policy for spontaneous onset of labor desirable. I've told that when a patient presents with PPRM, and you have seen that it is leaking since 2 hours, there is a wise decision of waiting for another, say, 12 hours to 24 hours, because the spontaneous onset of labor could be there for that. And antibiotic prophylaxis from the beginning, and method of induction, oxytocin if the cervix is favorable, prostaglandins and mechanical methods, individual judgment if the cervix is not favorable. Place of cesarean failure of medical methods of induction, malpresentation, previous scar, and planning for next pregnancy and further management for that. Problem 11. 29 years, gravida 2, para 1, first spontaneous vaginal delivery 3 years, female child, irregular ANC, spontaneous onset of labor at 38 weeks, uneventful progress of labor, delivery of fresh stillborn male fetus, and this was my first experience. Till date is my only experience. I have seen it beforehand, and I found the fresh stillborn male fetus along with umbilical cord completely avulsed from the placenta. So I find the avulsion of the placenta and the umbilical cord and placenta was inside, and with a short cord length about 10 centimeters. Manual removal of placenta. It's a very rare case. What I mean to say, the cord factors, there could be cord entanglement, true knot, long cord is responsible for that. Short cord, this avulsion is there for that. Short and long cord traditionally less than 10 centimeters is designated as short cord, and more than 72, less than 30 centimeters designated as short cord, length of more than 72 centimeters designated as a long cord. And shorter the cord, more is the chance of avulsion for that. And in that era, before sonography era, there's no clue to diagnose that. But of course, with the current situation, the nuchal cord is invariably diagnosed by ultrasound. But the sonography and fetal medicine specialists who examine the cord quality, not only the number of vessels for that, but also whether it's absolutely long cord or a short cord can be diagnosed with the recent sonographic machine for that. So short cord is very uncommon. Sonographic diagnosis now can be possible, and prevention of such accident could be there. You don't allow for a normal delivery labor to occur. You do a section for that. G2P1L0, post-cesarean pregnancy, early neonatal death. Irregular ANC at 30 weeks, sonographic evidence of, at 36 weeks, sonographic evidence of single live fetus, 35.2 weeks, AFI is 8 centimeters. Very common occurrence. Normal choroidopter, normal kick counts, planned for elective CS. This is definitely an oligomnias. but it is a borderline oligamy. So that's why the obstetrician agreed for that. And deferred for 1 week for social reasons. Presented with pain, abdominal vaginal discharge after 5 days in midnight. At 12 midnight, she presented to the hospital and with postpartum pregnancy and onset of labor. Uterus contraction mild, FHS 130 per minute, regular, cervix half an inch long, was 1.5 centimeter, excess discharge. Just onset of labor. And therefore, the obstetricians become little complacent in the dead of night, and the patient was not having much of pain. It's not an active labor, but there was a uterine contraction was there. Decided for LSH in the morning hour. Planned cesarean. Early in the morning around 7 a.m. got a call from the nursing home that FHS was not localized. Sonography revealed IUFD. AFI is 6.5 centimeter. Within 5 days, LSH was done. Fresh stillborn male baby delivered with deep meconium stent like her, discharged after 3 days without a baby and crying. And the obstetrician also cried and repented why we have changed the decision. So here is an again example of decision versus deviations for social reason. Yes, all right, it could have been agreed for that, but early intervention in emergency hour, again second mistake for that from the obstetrician. Borderline AFI with the previous bad obstetric history is a concern. You should do it. You should not deviate it. If at all everything is normal, would have done then and there at 12 midnight. You should not have a complacent for that. An early intervention in emergency hours could have saved the baby. And obstetrician service is 24/7 job. You cannot be complacent. You sleep, the baby will sleep. Preventive obstetrics is an important arena for that. And after these particular situation analysis and case scenarios, let us discuss about the aftermaths, which I have already shown in the beginning about the video of the aftermath for that, the PT of the obstetrician for that. So what should be the aftermath of stillbirth? It is a personal grief. I've already conveyed that it's not the parents which is a grief, but the personal grief cannot be expressed. Professional image, losing your confidence and a biased idea, and subsequently doing a active mismanagement of the case. Violence, personal abuse to mob violence, press, consumer and clinical criminal case, and others are the aftermaths for that. And how to protect the aftermaths? First and foremost is competence. Acquiring a knowledge and skill is important, and that's why the purpose of this particular interaction of E-Gurukul, seminar, conferences, workshops, and adequate knowledge. There is a plenty of resource now for knowledge, but the practical application needs a teacher for that. Communication is important. The communication skill has to be completely different from the stillbirth than for other regions for that. Counseling, case records, case handling. I've given 7 C's: competency, communication, counseling, case records is to be there. So documentation, we are very poor for that. So case records has to be there for medical legal scenario. And consumer and criminal laws, you should know a little bit about consumer and criminal laws for that. And apart from it, you need a support from the community and society, like the Foxy and other societies will be behind you for that. And community also, you should have a good, if you have a good command over the community, people will excuse you and they will come forward whenever you are in trouble for that. So the key points and take home message: obstetrics is unpredictable, but obstetric decision is very crucial. The decision making is important. Stillbirth is a tragedy to couple and challenge to the obstetrician. Controversies regarding definition of the entity, age of viability, and WHO definition is to some extent a consensus, which I've elaborately discussed. Early fetal death to be considered a distinct, separate entity as far as the causes and management is concerned. Less than 20 weeks is miscarriage. After 20 weeks is IUFD or intrapartum death, fresh or macerated. Late fetal death, fresh or macerated stillbirth is of great concern to the obstetricians. And therefore, the emotion is much more as compared to the early before 20 weeks for death or miscarriage. Prevention and prediction, recognition of risk factors, and the role of intensive antepartum fetal surveillance and early intervention with neonatal support will certainly improve perinatal outcome. This is also an important thing. You do a good preventive and prediction survey by the different obstetric parameters, recognition of risk factors, and apply the intensive antepartum fetal surveillance and early intervention aided with the NICU facilities. In more than quarter, I have already again reminding it, 25 to 30% no identifiable factors could be found out. And this group poses a real challenge to the obstetrician. This is a grey zone. Accidents such as cord factor, silent rupture uterus, abruption, fulminant eclampsia are all betinoid in obstetric practice. All of a sudden they come and you cannot predict and prevent them. Routine GCT in all pregnancy and stabilization of blood sugar and control of hypertension could possibly help in improving perinatal outcome. We know that GDM and hypertensive disorders are the malady of the perinatal outcome for that and target for that to control. Sonography and integral technological aid to detect early fetal compromise presenting after 32 weeks of gestation. No more one single at NT scan or TIFA scan. You have to do more of interval growth scan, remembering that after 34 weeks the risk is much more for that, which is not detectable accurately by the clinical methods for that. Early intervention and improved neonatal care, a step towards improving perinatal outcome. And here I will say liberalized indication of cesarean section at appropriate time is certainly a step forward. In the context of increasing rate of cesarean section, I will again say that here is an indication by liberalized indication. Antepartum and intrapartum fetal surveillance although helped in dictating early fetal compromise, but still it has many gray areas that has to be explored. It is not foolproof. And mob violence and medical legal issues evolving around stillbirths is not uncommon in the current situation. And all these 7 C's you have to make it for tackling the mob violence as well as the medical legal scenario. So we have developed conceptual in science. We have developed the technological advances. And in the era of computer, in the era of artificial intelligence, I think future is there. And I hope the next generation of obstetricians, my students and grand students, will be more smart and more intelligent and can save the baby to a considerable extent. And future, I dream of a fetal sensor device. There are a lot of sensors which have been put. You can put a fetal sensor device and which can have an alarm signal, and we can see it. The obstetrician can remotely see in his mobile or her mobile with the alarm signal of red, yellow, and green. Green signal, everything's okay. Yellow signal, they will say that, yes, signal will say that my life is 7 days. My life is 2 weeks. My life is 2 days or 48 hours. And the decision is made by this particular fetal sensor device with artificial intelligence. And then the obstetricians are very, I think, relaxed, and obstetrics will be made easy for that also. I'm dreaming of that. I think this is the way to come out in future for that. And no more, we have gone more from the imaging sciences. We know that we have advanced imaging sciences for that. But the alarm signal by the sensor device will really predict us beforehand, and then we can do an intervention and tackle the situation, improve the perinatal outcome for that. So medicine is a science of uncertainty, art of probability, Sir William Osler has told. And again I say, it needs a standard obstetric care. Whatever the technology is there for that, that will help us. But human intelligence is human intelligence. If it is combined with artificial intelligence and the gadgets, I think it will give a good yield, a very good result for that. So standard obstetric care, where from you get it? It is the right decision. Standard obstetric care will get it. Where from the right decision will come? From experience it will come. And where from the experience will come? From wrong decision experience will come for that. And therefore, you have to do an introspection and analytical analysis and decision making for the future for that. But remember, obstetricians are at a crossroad in the present situation. Obstetricians are criticized by government commissions for performing too many cesarean sections and by the legal profession for performing too few cesarean sections. We are castigated for acting too soon on electronic fetal heart rate traces and prosecuted for acting too late on electronic fetal heart rate traces. We are criticized by women for making labor too regimented by the formulation of rigid protocols and chastised for making labor unsafe by failure to provide rigid protocols. So, because of this, we think that we cannot win, but we cannot leave obstetric practice. Now the young generations, the future generations are trying to leave obstetric practice for this malady, and they are more preferring endoscopy and infertility and ART procedures for that also. And if this will continue, I hope the future generation of medical faculty will visualize obstetricians an extinct species standing with rusty forceps in the exhibition hall and museum next to Tyrannosaurus in the Dinosaurus family. And I will label them as what is Homo obstetricus for that. Thank you very much, Team Juventus and my viewers, for giving me this opportunity for the 7th episode, series, 7th episode, on a very important topic, which I think that this is a very complex problem facing the clinicians day in and day out. Thank you very much.
Thank you very much, sir, for enlightening lecture on stillbirth and clinical dilemmas. Thank you very much, sir.
Thank you.
Please
Thank
stop
you.
the recording.
Thank you, sir.
Thank you.
Thank you.